Good afternoon, everybody. First of all, I would like to thank the European School of Urology for his kind invitation to this webinar titled Challenges and Opportunities to Integrate Patients' Preferences into Surgical and Pharmacological BPH Management. The webinar schedule will be about 10 minutes for presenter, about 10 minutes for questions after each presentation. Questions can be asked through the question portal. And this webinar is accredited with 1 European CME credit upon your completion of the questionnaire after attending this webinar. I have no conflict of interest. And nowadays, in my opinion, I think that the clinicians are lucky because we are living time for change, because we are moving from the stratified medicine era to the precision medicine era or personalized medicine era, in which we can individualize the treatment according to some characteristics of the patient or of the illness. But if we want to practice personalized medicine, we not only should consider the clinical outcomes like effectiveness, postoperative complication, we should consider as well outcomes that really matter to the patient. Is to say, we should know what are the expectations of the patient with our treatments. And of course, we should know and inform to our patients about the impact on their life of our treatments. In BPH, in the last year, we have changed a lot the patient profile. And nowadays, we have 2 different types of patients. We have the first group is all patients with a high number of comorbidities, is to say, they are fragile patients. And the second type is old man with a high quality of life that wants to preserve or to keep the sexual function with the treatment that they received. And our patients ask us for a less invasive procedure in BPH. They ask us for a low postoperative morbidity, and of course, they ask us for outpatient procedure. Finally, the surgical scheme in BPH has changed a lot, and nowadays, we have a wide offer of minimal invasive technology in which we can offer our patients an individualized surgical treatment according to their characteristics. So today, for discussing about these topics, we have 2 excellent speakers. The first one is Dr. Carmen González Anguita. She is the head of Urology department at Fundación Jiménez Díaz. And in my opinion, she is the Spanish urologist that has a great experience in the integration of the patient in the process management in different urological disorders. And our second speaker is a young urologist, is Dr. Ivan Schwartzman. He is consultant urologist at Fundación Puigverd Hospital in Barcelona, but he has a great experience in the surgical treatment of BPH with minimal invasive technology. Dr. Carmen González Anguita is going to try to answer the question, how can we integrate patient preference into decision-making in BPH? And Dr. Ivan Schwartzman is going to try to answer the question, how to personalize the surgical treatment according to the impact of the new technology in this pathology. So for Dr. Carmen González, I'd like to answer the question, how can we integrate patient preference into decision-making in BPH when you want?
Thank you. Thank you so much, Dr. Lucia, for your presentation and the EU for this invitation to participate in this interesting webinar. It's a pleasure for me to be here with you. It's a very important topic we are going to work today. There are more and more of us individually, collectively, and institutionally who are convincing that nowadays making a therapeutic decision for the treatment of BPH involve taking into account the patient expectation and preference, as well as the need to adapt to treatment of patient general condition. Now, new evidence adds new tools to help the clinician to make a proper treatment decision in this pathology. These are my disclosure when I have the opportunity to work as a speaker, consultant, or clinical trial investigator. Experts say that communication is the best tool for healing. I want to tell you a short story from this book, Talking with Patient, the theory of doctor-patient communication. During the 1930s, my grandmother saw a specialist about a melanoma on her face. During the course of this visit, when she asked him a question, he salted her face, saying, "I ask the question here, I'll do the talking." Can you imagine such an event occurring today? Melanoma may not have changed much in the last 50 years, but the profession of medicine has. According to the author, to Dr. Castle, spoken language is the most important diagnosis and therapeutic tool in medicine. Spoken language. We must be as precise with it as a surgeon with a scalpel. So the importance of the anamnesis, we have to learn the process of anamnesis well, how the doctor can make the most of patient information. Patients are complex, changing psychological, social, and physically. Their diseases are well represented by their own communication. Doctor can use languages to the patient maximum benefits. Listen and speaking, art that we can learn better, and the important type of to speak, the paralanguage, this non-verbal phenomenon, how to make pause, speech, the rhythm of the speech, the way patients describe themselves or their illness, the logic of conversation, the level of meaning of word. In the 1990s, American medicine was in the middle of a professional evolution, driven by a refocusing of medicine rural for the patient viewpoint. Medicine was centered in physician, but to incorporate patient perspective, this kind of medicine method changed to patient-centered care. Evidence-based medicine, described for Sackett in 1996, is a new approach to medical practice. In the last year, doctors practiced a deliberative model versus paternalistic model before, making a therapeutic decision, sharing decision-making, the patient empowerment. The evidence-based medicine requires the integration of individual clinical experience, clinical evidence available, clinical status of patient circumstances, and taking into account the values patient preference. While MBA is conceptually anchored in research, PCM is in medical care. Both movements are emergency strongly in the healthcare system. MBN, the focus is in the population. PCM in the personalized approach. Medical decision-making, patient preference and perspective become a standard component in a medical record. How to mix MBM and PCM? We have to make confluence between both research and healthcare, to improve the care of individual patients. PCM should not be practiced without being based on the base available evidence, and it's impossible to imagine an MBM whose ultimate goal is disconnected from the individual patient. Even in clinical trial, we can see in this paper from a Spanish writer who patient preference patient is introduced in clinical trial. So in all areas of medicine, the wisest decision is taking into account the patient preference. And to do this, is necessary to individualize. This is the feeling of my hospital. I work in a hospital group, a big hospital group, where from 2010 has been immersed in a work philosophy where health, patient in the middle, and efficiency are the three strategies agents. A work philosophy, patient-centric, where patient is our greatest asset. Because only when you work in a patient-centered medicine, result in patient satisfaction. It's more efficient, sustainable, and lead to adherence. The basis of clinical practice of the sense of medicine is to know that each patient is different and a patient is more than just his illness. So taking always into account, because each patient is different from another, the patient profile. Look for it. For example, when the EUA guideline 2022 is discussion about medical or pharmaceutical treatment for BPH, notice that the choice of treatment depends not only the patient evaluation of the ability of the treatment to change the finding, but also include the treatment preference of the individual patient and patient expectation in terms of speed of action, efficacy, side effect, quality of life, and disease progression. We can see in this recent paper, 2022, a new model of predicting the result of treatment in order to study the IPSS or the risk of retention urine or surgery for BPH, based in a long list of data, or for using to help to prediction a basis characteristic for commonly define the risk of BPH disease progression. Reinforce the individualization in the management on looked in BPH. And note how patient-centered medicine has also changed the publication, including a message to the patient summary. It's not easy to understand the results, so this web app visualization can help physicians to better understand a study result and to highlight the importance of individualization for the treatment. Since Emerton work in 2010, we know that the perception of BPH treatment results are not always the same between doctor and patient. We have working on patient preference. When we have working preference, you need to reach agreement. We have to study different possession of the patient, mental, social, physical, and functional, to taking into account the patient, the person. We have to study the morbidity, polymedication, the loss of independence, the body schema, living habits, family, and social environment. And how will you incorporate, how we incorporate patient preference into clinical practice? with a new methodology that I can't time to explain in this presentation, but it's very important to know because perhaps in the future, all of us, we are going to work in this methodology, is the value-based healthcare. And ITON, it's an international consortium for health outcome measure that work in this sense, studying the global and integrate patient need. This organization comes from Mr. Michael Porter for the Harvard University in 2012. They are working about quality standard. There are different sets of outcome measures that matter most to patients. Unfortunately, in urology, BPH is not included. It's included prostate cancer, localized and advanced, and overactive bladder, but not yet BPH. Here you are, the different prompts and prems that we have to use, we have to get used to working in clinical practice, and the website where we can one has been rarely used in urology. But, however, the management of LOT and BPH may represent the perfect ground to experiment and improve this approach. This paper, for example, resonance evidence saw a dramatically low drug adherence and satisfaction in medical treatment in LOT BPH patients. And a patient-centered approach may improve drugs adherence and some unmet needs in this area, potentially reducing complication and cost. Further well-designed studies that are needed to confirm this data. For example, this experience, recent experience in 2022, is an online survey study around a lot of participants, more than 1,200, that they need to study the result of different pharmaceutical medication for different patients using IPSS, the International Prostate Score. The result is relevant. The most important for patients is not to have complication with this medication. And after that, after the complication risks, the efficacy, the recovery difficulty, and the risk of ejaculatory dysfunction. And if you have a look at the young people in this survey, we can see the same. The complication rate is the most important for all of them. After that, the ejaculatory dysfunction. So one more time, individualize each case to maximize the patient satisfaction. And to reach this, patient must be informed in order to be able to choose. In this sense, for example, AAU in the website for patients have different information. For example, this video, who is able to explain the patient all of things around the BPH. This is my last slide and my last message for all of you. It's a double message. The first one, I hope you like it. I think it's very interesting to talk in this moment about this topic. And I want to change the way to do medicine, the way to view the patient we treat in clinical practice. Thank you. Thank you very much for your attention.
Thank you very much, Carmina. Excellent. It has been an excellent speech, and we have some questions from the audience. And so the first one is, do you think that in BPH we have enough tools for individualizing the treatment nowadays?
Yes or not, both. I have a double feeling. Perhaps we have one, two, or three, but it's not enough because we don't have the possibility to use in a clinical practice. For example, the first one was the IPSS, the questionnaire that is from 1992, created for EUA. And it's using this questionnaire, we can discover different symptoms, patient symptoms, feeling, emptying, and the impact of the quality of life, exploring the last question. We know it's had very limitation. For example, it's not evaluation for urine incontinence, no evaluation post-micturition symptoms, don't include the age, but it has a very level of evidence, 3, but it's a strong recommendation. After that, the bladder diary is not using true, and it's a very tool to explore the frequency, the volume, the void and volume, the urine loss, and the fluid intake. And perhaps the last one, the one I have spoken before, the recent statistic model for predicting the treatment repose. So we have in this moment 3 to use in clinical practice, but I am not sure it is possible to use because we have a lot of problems to incorporate in our routine, in our how to do the medicine.
Thank you very much for your comments. We have another question from the audience. Is what reasons do you think that there are for a low adherence to drugs in BPH? You have commented in your presentation that patients have a low adherence to the treatments in BPH, and the question is about that. What are the reasons, in your opinion?
Thank you very much for this interesting question, because I believe the question is key. It's very, very important. I believe the patient has low adherence to treatment because we don't able to identify different patients with similar symptoms. We have to study the patient profile. We don't have able to choose the most appropriate treatment for a particular patient. The third reason, it will be perhaps we don't have able to do the patient-centered medicine. We don't work on the patient expectation. We don't work with the preference and don't reach the agreement with the patient. In this scenario, it's difficult to get an adherence. We have to communicate better, and we have to talk about the side effect, for example, to explain well. And finally, I think we are working with BPH, that is benign pathology, and it's different. We are not so rigorous as it were an oncological situation, disease.
Mm-hmm.
Many
yes,
reasons.
I agree with you. I think that you are right. Okay, I have a new question from the audience as well. And they ask for how do you integrate the patient's preference in your clinical practice? Because sometimes it's not easy to do that. And sometimes we have not enough time to listen to the patient in our office. So do you have some trick to integrate the patient's preference in your clinical practice?
I have some trick, but perhaps my last slide is the most important trick. To view the medicine different. We have to change ourselves before. We have to be aware that the patient, it's necessary to be part of this decision and to believe in this way to do the medicine. We have to use pros and cons, I know it is difficult because we don't have time in the clinical practice. Perhaps I don't know which kind of prompts or prompt to use. So I saw you the website to find them, and it's very easy. It's necessary to know all different tools that we have and using them, and overall give the opportunity the patient to talk, to share their concern, the problem, and to make choice in the same way that with us. The confidence with the patient, with the doctor.
Thank you very much. We have another question that is about how long time is take your first session with patients with BPH?
My first
Because
session,
yeah.
No, it depends on the patient, but it is possible more than 20 minutes. My first consultation, are you talking about that?
Yes. The question is about the first session or the first consultation in your office, because you have to explain a lot of things. You should ask for the preference of the patients if you have to discuss some treatments. And the question from the audience is, how long time do you use in your first office?
Around 20 minutes. If I want to explore all symptoms, the personal symptom before, all of them, and to share my impression, my diagnosis, and after that to choose the better treatment for this kind of patient. 20 minutes.
It's a long time for us.
Yes, I know.
For a visit, because we have a high pressure in our office, so it's a long time.
We had to fight to prepare the time necessary for each consultation, and the head of the department have to fight for this situation with our headquarters in the hospital.
I agree with you. Thank you very much for sharing your experience. We are moving to the next presentation by Dr. Ivan Swartman. We have more questions, but I think that we discussed them when Dr. Ivan Swartman finished, and we can discuss, or both of you could discuss the new questions that we have received.
Thank you.
So, Dr. Ivan Swartman, you can ask the question, answer the question that I made before. So you have the word when you want.
Thank you very much, Dr. Budia and the European School of Urology for the invitation. These are my potential conflicts of interest. And there are many challenges. Well, I'm going to talk about 3 challenges in personalizing surgical treatment. The first challenge is who to operate on. This might sound very obvious, but we know LUTs have very different causes, and we want to operate patients with BPH and not patients with other causes. And also we have to take into account patient preferences. We know from this online survey of Hoffman and colleagues that globally, and especially older patients, care mostly about the risk of complications in surgery, and younger patients care a bit more about the efficacy of the treatment. So we have to take these things into consideration. Also, the systematic review of Malde and colleagues observed that patients have preferences for less risky options and will tolerate symptoms to avoid the risks of surgery. And they will only prefer surgery when symptoms are already severe or when surgery has a high success rate and a low complication rate. We also know that there are some conditions that increase the risk of continuing LUTS medication after BPH surgery. And these risks are mainly an older age, a history of diabetes or stroke, and previous use of anticholinergic or beta-3 agonist drugs. So we have to also take into account. The second challenge is when to operate. And this is a bit harder to answer. We know about this with this great work from Fusco and colleagues, that persistent bladder outlet obstruction leads to remodeling of the bladder, and it's a damaging remodeling that leads to decompensation of the bladder function. And when this is persistent in time, it can be permanent and not be solved by surgery. So when to operate when we have moderate to severe symptoms, but before it's too late. This is something that is a bit hard to pinpoint, but we should bear that in mind. And the third challenge is how to operate. What techniques do we use? The classical pathway for surgery was we go to medical treatment, and when it fails, we go to surgery. But standard surgery has improved, and it has a lower morbidity thanks to advanced techniques in anesthesia and advanced technology in surgery. And also we have the appearance of minimally invasive surgical techniques. And this might change a pathway. Is it a middle step between medical treatment and standard surgery? Will minimal invasive surgery replace standard surgery, or should we offer all three possibilities to patients? And to answer these questions, we should learn what does minimal invasive surgery has to offer. We're going to review three types of minimal invasive surgery. We're going to start with Urolift, because it's probably the, let's say, gold standard of minimal invasive surgery, because there's a lot of evidence available for it. Its mechanism of action is pretty simple. It produces a compression of the prostatic tissue that is held in place through a series of staples that are left inside the prostate. We know from studies like the BPH-6 that compares Urolift with TURP in 10 European centers and followed for 2 years, that it has quite acceptable efficacy. IPSS improvements is around 45%, maximum flow rate improvement is around 4 milliliters per second, and ejaculation was spared in 100% of patients. So very nice numbers. When compared to TURP, IPSS improvement and Qmax, maximum flow rate improvement, is not as good as with TURP, but of course, ejaculation sparing is better. Regarding surgical retreatment, we know from this systematic review by Miller and colleagues, this meta-analysis by Miller and colleagues, that the annual surgical retreatment rate is around 6%. And we have to consider surgery after Urolift. This study by McAdams and colleagues in 7 holds after Urolift observed 7 clips in aberrant locations that required special maneuvers to retrieve the clips, and they interrupted modulation as well. So good things about Urolift: the effect is immediate. The patient doesn't have to wear a bladder catheter. It's an outpatient procedure. Ejaculation is spared, and there's abundant evidence on it. Of course, there are bad things about Urolift. There's little evidence of treatment on the middle lobe. At the beginning, it was a contraindication for Urolift. Now there are some surgeries treating also the middle lobe, but there's not that much evidence on it. We have a prostate volume limit around 80 grams, and we have to leave permanent implants in the prostate. The second minimal invasive technique is Resum. Resum's mechanism of action is an energy transfer in the form of water vapor. This energy transfer produces necrosis in the prostatic tissue and decrease in the volume of the obstruction caused by the prostate. This meta-analysis by Miller and colleagues analyzes 1 randomized controlled trial and 4 cohort studies, and they observe that there is a considerable drop in IPSS and quality of life score, and this improvement is maintained through 4 years of follow-up. Also, that the annual retreatment rate is around 1.75% for 4 years of follow-up. Good things about Resum: it's an outpatient procedure. It can be done under sedation. Middle lobe treatment is possible, and there are no permanent implants. Of course, there are bad things. The patient has to wear a bladder catheter for around 5 days. The improvement is very progressive. It can take between 3 and 6 months. We have the same prostate size limit at 80 grams, and there's scarce evidence, especially compared to Urolift. And for time, the last minimal invasive treatment I'm going to talk about is aquablation. The mechanism of action is quite different. What the surgeon does is an ultrasound-guided mapping of the area to treat, and then a robotic arm produces a dissection of water jet dissection of the prostatic tissue. So very, very different mechanism of action. The water study compared aquablation versus TURP in small prostates, and they observed that IPSS improvement was similar between aquablation and TURP. Maximum flow rate was better for TURP, ejaculation sparing was better for aquablation, and hospitalization was similar for both groups. The Water 2 study treated prostates up to 150 grams, and they observed similar improvements as the patients treated with aquablation in the Water study. So good things about aquablation: the resection time is very low. The roboticized procedure is very, very fast. You can treat endoscopically prostates to up to 150 grams with a low level of resection skills because the resection is done by the robot. But the total surgical time is similar to TURP. Consider anesthesia, planning, and coagulation. You have to coagulate with a loop after the procedure because otherwise it would bleed. The patient has to be under general anesthesia. It's an inpatient procedure. It has a high red blood transfusion rate, and there's scarce evidence about it. And with these characteristics, the question arises, is it minimal invasive? In my opinion, it's not. It doesn't make it a bad procedure at all, but I think it's not really minimal invasive. And going back to standard surgery, the question arises, who can challenge the gold standard? TURP is the gold standard, not because it's necessarily the best procedure nowadays, but because it has the most available evidence. And who can challenge the gold standard? Well, HOLEP probably. If someone, I would say HOLEP. As we know from this meta-analysis by Cornell and colleagues, HOLEP can show a favorable profile regarding IPSS improvement and maximum flow rate improvement compared to TURP. There are many meta-analyses that show that HOLEP has a higher operation time, but shorter catheterization time, lower blood loss, and lower transfusion rate when compared to TURP. Also, the retreatment rate is quite similar between both of them. And what's new in endoscopic enucleation? Well, mainly different types of lasers. Holmium pulse modulation, thulium fiber laser, and the new pulse thulium YAG lasers. All these improvements will probably improve the relationship between coagulation and the burst of the bubble that allows mechanical laser dissection. And very, very important, more mentoring. All of these improvements will shorten learning curves and allow new surgeons to have fewer complications while they learn. So quick comparison of the different techniques regarding prostate volume treatment capability. Most minimal invasive surgical techniques have a limit around 80 grams, and also TURP. Aquablation pushes this limit a little bit up to 150 grams, and of course HOLEP erases this limit completely. It can treat prostates of more than 300 grams. Regarding IPSS improvement, minimal invasive techniques don't get the level of IPSS improvement that TURP or HOLEP achieve. Aquablation is in orange because I don't think it's minimal invasive. QMAX improvement, maximum flow rate improvement, is the same story. It's not as good as TURP, but ejaculation sparing is a lot better than alpha blockers and of course than TURP for most minimal invasive surgeries except for prostatic artery embolization. The annual retreatment rate is a bit worse for minimal invasive surgeries compared to TURP and HOLEP, and here is higher for UroLift, but we should remember that there's scarce evidence for resonant aquablation, so more evidence might increase this annual surgical retreatment rate. So some take-home messages to finish. We should tailor surgery to patients' preference and expectations, but also to their comorbidities and pathophysiology. So it's not just what the patient wants, but what the patient wants and what's better for that particular patient in his particular situation. As Maverick said, it's not the plane, it's the pilot. Of course, the surgeon is very, very important, but surgeon skills and experience is important, but you should know each technique's advantages and limitations. You can't do everything with any instrument. We should know the difference between medical treatment, minimal invasive surgery, and standard surgery. Mainly, minimal invasive surgery has a favorable profile regarding complications and sexual function, but its efficacy is lower than standard surgery. Thank you very much for your attention, and I look forward to your questions.
Thank you very much, Ivan, for your excellent speech. I think that you have reviewed all the new technologies with a very exhaustive review of the literature. So thank you very much and congratulations for your presentation. We have a question from Pakistan. They say that for the patient, age is a priority for the patient, because sometimes the patients, when it comes to the office, they say, I will not be fit for surgery in the future. I want to perform, or I want to do or to make a surgery because the problem is the age. Perhaps in the future I will be unfit. What do you think about it? What do you recommend your patients when someone says something like that?
No, it's a very, very interesting question. There's a study that showed that when medical treatment appeared and TURP indication was delayed, the results were not as good. So there is kind of a point, not only for patient comorbidities, but also from results of patients, we have to take into account that delay in surgery will can make the results of the surgery worse. But of course, you should never operate a patient that doesn't need it, because you can't know what the progression will be. Maybe he will need surgery in the future, but maybe he will not. And if the indication is there now, with less morbid treatments, less complications than before, it can be acceptable to use medication for a shorter time, but the symptoms and the root cause of the problems has to be there. I mean, you have to be a patient with moderate or severe symptoms, and that the problems are caused for BPH. There's no prophylactic surgery. There shouldn't be any prophylactic surgery for BPH, at least in my opinion.
Mm-hmm. Thank you very much. We have another question from Saif Hamed Mohamed that they say, what is nowadays the paper of the open surgery in BPH? Well,
I would put myself in the skin of the patient, and I would rather have a good experienced surgeon on open surgery operate on me than a completely inexperienced surgeon on HoLEP operate on me through HoLEP. So open surgery, of course, is a good treatment. It has more comorbidities than endoscopic treatment, but if in an expert hands, it's a very good option in regarding outcomes. It has very, very good outcomes, very good durability. The level of the obstruction is very, very good. And if you don't have the resources or the expertise to perform, let's say a HoLEP, because it's a prostate, let's say to 200 grams, it's better to perform, I think, an open surgery until you have the capability or the possibility to send the patient to another center. If you have both options, of course, endoscopic anatomic enucleation of the prostate is the better option, but that doesn't mean there's no room for open surgery.
Mm-hmm. Thank you very much. We have another question from the audience. Because you have spoken about a lot of techniques, but what is the paper nowadays of the green light laser? Do you think that the green light laser has a paper into all the techniques that we have nowadays?
To answer this, I like a quote by Dr. Fernando Gomez Sancha that said, he said that an expert enucleator can enucleate with a spoon. So if green light is a technology you have available and you can learn, you have a mentor that teach you green light vaporization and green light enucleation, it can be a good tool for enucleating. It can of course be performed. I think it's a bit more challenging to perform enucleation with green light, and also the fibers can be a bit more expensive. So that's why it has lost, I think, a bit of popularity in the last years. But of course, it's a good technique. It's a good laser. It has great, probably the best coagulating capabilities. Fernando Gomez Sancha and Dr. Ferrari and many others have shown that it can be absolutely safe to perform enucleation. So of course, if you have access to a green light, it's possible to make enucleation with green light.
Mm-hmm. Thank you very much. There is a question for the audience as well that say, do we have any studies related to urodynamic parameters before, after the use of minimal invasive technology?
Yes, urinary parameter. Well, most of the studies are presented compares parameters before and after surgery, like IPSS improvement, maximal flow rate improvement, quality of life improvement. Well, I think they mean those parameters.
It's urodynamics parameters.
Urodynamic studies.
Urodynamic parameters.
Yes, that not that I'm aware of. You have to question though whether it's it would be a bit challenging to perform a study performing urodynamics on every patient before minimal invasive surgery, because it's an invasive test and probably not necessary. Might be one out there, not in my memory right now.
Okay, thank you. There is another question from the audience as well that he's asking about if the minimal invasive therapy in Spain is covered by the health insurance or by the public system health.
Yeah, it is. We have a healthcare system that is divided by let's say states or autonomous communities here, and it depends on each community, but it's starting to be adopted. At least I know in my hospital, many hospitals in Barcelona already are performing different types of minimally invasive surgery.
Mm-hmm. And for an old patient and fit for surgery, which is your first preference if you have to perform a surgical procedure or a destructive procedure? It's a fit patient for surgery. What paper do you think that IT can be in this scene?
Mm-hmm. Well, that's a good question. That's interesting to answer. IT has very little evidence, but what evidence it has, as many of the minimal invasive technique, is positive. There are many surgeons that say that it has very, very good results. Most minimal invasive surgery, the thing is that if it's a patient that is only fit for IT and not fit for, let's say, urolift or prostatic artery embolization, it can be a very particular patient. Minimal invasive surgeries are really minimal invasive, and there are very few patients that can't be subject to, let's say, an IETine or a resum or a prostatic artery embolization. IETine definitely has a role. We need more evidence about it, but any minimal invasive also has a role in this type of patient. Unfit for surgery, that's a good option for the patient, definitely. Better than leaving him with a bladder catheter.
Thank you very much. There are another question from the audience as well. What are the recommendations for patients with a small prostate, less than 30 centimeters, and high post-mixing residue after resection, transurethral resection? It's for a rescue surgery after a GU repair, that in which we have a low volume of prostate. What are your recommendations for patients with a small prostate after a first surgery with transurethral resection? This is a question from the audience. Mm-hmm.
Mm-hmm. Yes. Probably if you have, I would do a cystoscopy first to really know if you have a residual spheroid or a regrowth of the prostate, or you have a bladder neck sclerosis, or if you have urethral stenosis, urethral stricture. I would try the cause of the problem, but first I would do definitely a cystoscopy. If it's just prostatic tissue that is left behind, I would do a re-TURP if it's like a spheroid that has regrown. If it's a problem in the bladder, I would the bladder neck, I will treat the bladder neck. I think the energy used in this, like if you cut the bladder neck with laser or with plasma energy, hasn't shown to make any difference in the studies available. So it would just be treat the root cause of the persistence or the reappearance of the symptoms in this type of cases.
Okay, thank you very much. My question is, what is your preference in the selection of the laser for enucleation? Because you have spoken about 3 different lasers. And my question is, what is your preference, or which is your preference for using in the enucleation procedure?
Well, short answer, holmium. Long answer, depending on the patient. Holmium has a great speed for enucleating. It's a very comfortable laser to use. But I also have available the thulium fiber laser. And in small prostate, it is a lower power 60-watt laser. And in small prostates, there's not a lot of difference in time of the surgery, but it has a lot better hemostasis. So in a patient that you think that is going to bleed a lot, he can suspend anticoagulation or anticoagulation, or in general, you suspect the risk of bleeding is high. And he has a small prostate, let's say 60 to 80 grams. Thulium fiber laser would be a great option for me, because I have it available, that it's not very common to have 2 lasers available in your hospital.
Mm-hmm. Thank you. In your opinion, are you agree that the enucleation will be the new gold standard in the future, when the resection, transurethral resection, is going to be displaced by enucleation? Because we have a lot of studies, we have read a lot about that, but enucleation never arrives to be the new gold standard. When do you think that is going to occur? That
I think it's going to happen. I think it's a matter of, always like the fight between TURP and enucleation. I think it's just a matter of time. Like more and more studies about laser enucleation are coming. New lasers are coming that make enucleation better. People are learning now with mentors and not by themselves, which will improve results and with shorter learning curves. So I think it's a matter of time. If I have to make a bet, I would say, I don't know, maybe 2 to 5 years it will change. I think it's imminent, but of course I'm biased.
For example, for you, when you receive a patient in your office and the patient has impaired with the medical treatment, and nowadays you have to decide a surgical procedure. The patient has a middle size of prostate, about 50 centimeters. So what is your preference for the patient? Do you try to individualize the treatment with the patient, with the preference of the patient? Do you consider the sexual activity? Do you consider the possibility of comorbidity? I like to know how do you individualize the treatment when you have a patient, a fit patient in front of you?
That's a great question. The first thing is, what is the patient fit for? No, what like, as you said, a patient with a small prostate. I would generally, I just present both options. In my hospital, for example, we have a restroom available and enucleation with holmium and thulium fiber. I would just say, laser enucleation will give you a better result, probably longer lasting, but it's a more aggressive procedure. You will have to stay in the hospital for a couple of days. And then you have this restroom that probably the improvement won't be that much, but you will preserve ejaculation. And basically this, like you will preserve ejaculation with one technique and you will pee better for longer, probably with the other technique, and then some minor details. And I let patients decide. Like, I think it's the best way to do it, because ejaculation, for example, can be really, really important to one patient and not to the other. And other patient might be really, really afraid of a long procedure, or would not like to be in the hospital for a couple of days. So that's, if the patient is fit for both, I let the patient decide.
Thank you very much. We have a lot of questions from the audience, but I'm going to select only 2 or 3 because we have no time. One question is about, what would you recommend to prevent urinary incontinence in routine practice in your surgery?
In my surgery?
What do you recommend?
Well, locating the sphincter and looking back at the sphincter many times during surgery, especially during during HOLEP. I'm very cautious with the sphincters. The first thing I do is a white line, so I release the mucosa of the sphincter. And during the first third of the surgery, where until I have the sphincter completely liberated, I go back a lot and lose a little time, stop what I'm doing, go back. Where's the sphincter? Is it completely free? And then I go back in and continue. For me, it's being patient and looking back to at the sphincter many times.
Mm-hmm. Thank you very much. We are going to the last question. Okay, it's from Dr. Arif. I know the topic is BPH. However, can you shed any light on role of minimally invasive surgery in prostate cancer patients with moderate to severe symptoms?
Oy. It's
a difficult question.
It's a difficult question. It's a question I have no experience in, and I think there's not any literature on. I can't really answer that question. Like, maybe if patient is going to radiotherapy, it may make some sense, but there's really no experience in that, so I wouldn't be able to answer that. I don't know how the cancer will react to the minimal invasive treatment. Also, it would depend on what treatment it is. For example, iodine probably wouldn't do much difference, but for example, Urolift goes all the way to the body of the capsule. I really can't answer that question with evidence or experience. I'm very sorry. That's a tricky question. You got me. The last one. Huh?
Yes, this is a difficult question, really.
What do you think? What would you do, Alberto?
In this case, I think that perhaps it's a destructive surgery and ask only for increase the quality of life of patients. So we can choose any surgery. Perhaps a transurethral resection is the traditional technique that we have used in these cases, and I think that is perhaps a good option for these patients to only improve the symptoms and the quality of life. No? But I think that is the patient needs a primary treatment for the cancer, and if the patient is obstructed and has a high symptomatology, in these cases, I think that the best option is to use the destruction technique with resection, transurethral resection in these cases. I think that the minimal invasive technique for this type of patient has no role. Is my opinion. I think.
I think I would agree.
Okay, thank you very much, Ivana. I don't know if Doctora González Tenguita.
Yes, I'm here.
Hi, how are you? Thanks a lot for your excellent speech. I think that it has been a very high quality webinar. The quality of your presentation is very. Thanks the effort that you have done for this webinar. Thank you very much. And I see you soon. Thank you very much for all the audience. I'm going to finish the webinar. Thank you very much again for all the attendees, and of course for the presenters and for the speakers. That is really a pleasure to listen to you and to share your